All right, so we go again. We have patients who experience increased susceptibility of the skin to sunlight. Sunlight. If you guys can remember yesterday, we spoke something about what? Sunlight, and we said it was what? A congenital erythropoietic what? Purpura. Congenital erythropoietic what? Purpura. Porphyria, sorry. Porphyria. Porphyria. Now, his urine after some time became dark red. So what are you thinking about? Again, you are thinking of what? Porphyria. Porphyria. So here, your answer will be what? Will be C. So these people, their skin are very, very what? Sensitive to the light. As a result, there will be hemorrhages all over their skin, or there will be erythema, redness all over their skin. Okay, so these are very, very what? Susceptible to sunlight. Sunlight. So here you are thinking of what? Of C. Aha. By now you should know what pellagra is. Pellagra is what? Vitamin B3 deficiency. Vitamin B3 deficiency, or niacin, or nicotinic acid, or nicotinamide. And it has 3 Ds. Diarrhea, dementia, and then what? Dermatitis. Good. All right. Now we have a patient with a serious damage of muscular tissue. Now, if you can remember, I made mention that anytime we have muscular tissue, what comes to mind? We are thinking of what? Creatinine level being what? Present. Am I right? And they said this patient was admitted to the traumatological what department? What? Biochemical urine index. Now, when in the blood, you mostly be looking at for creatine. But in urine, you are looking for what? Creatinine. There are 2 different things. We have what? Creatine, and we have what? Creatinine. So creatinine, we are looking at what? It in the urine. So we are seeing how your kidney is functioning. So usually this is a marker for testing how good your urine is, or how good your kidneys are. How good your kidneys are. So you don't have to say BUE creatinine. So that's what we are normally what? Referring to. BUE and what? Creatinine. So here you are thinking of what? Of A as your answer. A as your answer. Again, if it is uric acid, you know of uric acid, right? So you are thinking of what? Xanthine oxidase. You are thinking of purines. You are thinking of what? Adenosine monophosphate and all those things. Thank you. So here your answer is what? Is A. A is your answer. We have a 12 hours after an acute attack of retrosternal pain. When we say retrosternal pain, it's probably has to come from the heart, okay, where you feel that there's pain behind your sternal bone, or in the middle of your chest. You feel that there's a pain at the back of it. And they are saying that this person presented with an increase in aspartate aminotransferase activity. Guys, do you remember we talked about what? Creatine. We spoke about AST. We spoke about LDH. Yes. And we said when somebody is coming with aspartate, you are either thinking of the liver or you are thinking of the heart. Now over here, they didn't bring LDH1. If the LDH1, of course, we know that this is what? Myocardial infarction. But over here, what gives us the clue here also that is that we are having what? Retrosternal pain. Retrosternal means it's coming from the heart as well. It could be coming from the heart. And that's why over here, you can easily still say this is what? Myocardial infarction instead of viral hepatitis. So you are thinking of what? Myocardial infarction because of the pain. Because aspartate is not exclusive for the heart. However, LDH1 is exclusive for the heart as well. All right, so here I'm thinking of what? B. Okay. So we have a donor skin transplantation was performed to a patient with extensive burns. On the 8th day, the graft became swollen and changed color. On the 11th day, graft rejection started. Usually, graft rejection has to do with what? Type 4 hypersensitivity. Type 4 hypersensitivity. And usually, what cells comes to play are what? Are the T lymphocytes. Are the T lymphocytes because they are cell mediated. They are cell mediated. So you are thinking of what? T lymphocyte or natural killers, natural killer cells. They are all what? T lymphocyte. T lymphocyte. And this is what? Type 4 hypersensitivity reaction. Okay. So here your answer is what? Is E. We are having a 30-year-old woman who had been ill for a year. And when she felt pain in the area of the joint, so there's pain in the joint for the first time, they got swollen and the skin above them became what? Reddened. Guys, look, provisional diagnosis is rheumatoid arthritis. Rheumatoid arthritis. One of the most probable causes of this disease is a structure alteration of the connective tissue. Ladies and gentlemen, when we talk about the connective tissue, I know I've mentioned about it, but connective tissue, one of the most dominant substances is what? Yes, is the collagen fibers. Collagen fibers. This is the most dominant part of the connective tissue, or the most dominant structure of the connective tissue. So when there's a problem with the connective tissue, mostly we could be thinking of what? The collagen fibers. We could be thinking of collagen fibers. So here we are thinking of what? Of E as our answer. All right. So we have an autopsy of a 12-year-old girl revealed multiple cutaneous hemorrhages, mostly into the skin of the buttocks in the lower extremities. There is serous and mucous membrane hemorrhages, cerebral hemorrhages, adrenal gland show focal necrosis and massive hemorrhages. Kidney shows necrotic nephrosis, suppurative arthritis, iridocyclitis, vasculitis. What are you thinking about? So the question now is, what kind of infection does not only stop with the skin, but also attacks the brain and even other organs? And here you are thinking of what? Meningococcal infection. You are thinking of meningococcal infection. And this person could even develop meningeal symptoms. Meningeal symptoms, because there's what? Cerebral hemorrhage. And in cerebral hemorrhages, you are likely to find what? Meningeal symptoms. Meningeal symptoms. So here you are looking at for what? Meningococcal infection. Meningococcal infection. So here your answer is A. We are having an examination of a 27-year-old patient, revealing what? Pathological changes in the liver and the brain. Now, the blood plasma analysis revealed an abrupt decrease in copper. So this is your clue. Copper, 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 copper. So the question now is, how are we going to, or what tool, what test do we use to determine this copper concentration or this copper being present in the blood? And the answer is what? Ceruloplastin. 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 This is it is the major copper carrying protein in the blood. So if you see too much of ceruloplasmin, it means copper is so much what? High. Copper is so much what? High. Copper is so much what? High. Now, the question is what? The patient was diagnosed with what? Wilson degeneration. And Wilson simply means what? There's increase of what? There's increase in amount of what? Of copper. Don't forget, they say urine analysis reveal what? An increased copper what? Concentration. Increase in copper what? Concentration. So that means they are being what? Excreted. They are being excreted. They are being excreted. So here you are thinking of what? Plasmine, sorry. So here your answer is A. Again, I believe you can remember xanthine oxidase. Xanthine, it has to do with what? With uric acid. With uric acid. Okay. We have a patient complaining about dyspnea, that's difficulty in breathing, provoked by physical activity. Clinical examination reveals anemia and the presence of paraprotein. Paraprotein simply means too much of what? Proteins, or a tumor of proteins. Basically, tumor of what? Proteins. So there's what? Abnormal concentration of what? Of plasma cells. And these plasma cells contains what? Or produces a lot of what? Proteins. They produces a lot of what? Proteins. And how do you confirm? You confirm by using what? Benz-Jones proteins. Benz-Jones proteins. Benz-Jones proteins. Benz-Jones proteins. So sometimes you will not see paraprotein. You might see myeloma. That is MYELOMA. Myeloma. Myeloma or plasmacytoma. Plasmacytoma. All of these simply means that there is too much of what? Of proteins in the body. So of course, we're talking about gamma what? Globulins or immunoglobulins. We are thinking about what? Abnormal amount of it. So we use what? We use Ben-Jones proteins to confirm that indeed, you see, myeloma, to tell that indeed there is the presence of this. And again, what is this one used for? Ceruloplasmin is used for what? Copper. Good. All right. We have, as a result of exhausting muscular work, again, question has been what? Repeated. Muscular what? Work. When you are working, you are using your muscles. And when the muscles are being utilized, low amount of oxygen will come to play. So the what? Anaerobic what? Respiration. So how will you produce energy? You have to use what? Lactate, or the energy produced, or the acid that comes as a result is called what? The lactic acid or lactate. So your answer is what? Is D, lactate. But you see, it's producing, they've formulated the question in a different way, but the same thing. We are having a 2-year-old child with mental and physical retardation was brought to the hospital. He presents with frequent vomiting after having meals. Guys, look, there is phenylpyruvic acid in urine. Phenylpyruvic acid. What is a phenylpyruvic acid? They are simply what? Amino acid. They are simply what? Amino acids. So the question now is, which metabolism abnormality is present? Of course, amino acid metabolism. Amino acid metabolism. So basically, the disease of this, where we have phenylpyruvic acid, is called what? Phenylketonuria. Phenylketonuria, also known as PKU, phenylketonuria. So basically, that is it for that. Okay, so here you are thinking of amino acid metabolism. And the disease is phenylketonuria. Phenylketonuria. That's the name of the disease. Okay. But they are all what? Amino acids. So there's a problem with what? Amino acid metabolism. We are having a patient delivered to the hospital by an emergency team in grave condition, unconscious, edema. Cutaneous surfaces are dry. The eyes are sunken, face are cyanotic. So these are signs of what? Dehydration. This is a sign of what? Dehydration. Now there's tachycardia and the smell of acetone. So that means that this patient could be suffering from what? Ketoacidosis or diabetic what? Ketoacidosis. Am I right? So this person is what? Diabetic what? Ketoacidosis. You can smell ketones. You can smell it. Guys, look at the blood glucose. 20. Look at the norm. The norm was 3.3 to 5.5. But here we are having what? 20. That is too much. And you see the glucose, 3.5. Glucose in urine is high. Standard is what? Is 0. So what are you thinking about? Of course, you're thinking of what? DKA or diabetic ketoacidosis. But that one is not here. So what comes to mind? You are thinking of that as what? As hyperglycemic coma. Hyperglycemic coma. But actually the right diagnosis is what? DKA. Diabetic acid, how do you call it? Acidic coma. Yeah. Ketoacidosis, sorry. So the answer is D. All right. We have a profuse foam. I think we did this. Profuse foam appeared when the dentist put hydrogen peroxidase on the mucus of the oral cavity. What enzyme caused such activity? And we said that hydrogen peroxide is being catalyzed, or it's what helps in the process or the reaction is what? It's catalase. That is why when there's an absence of foam, it means catalase is deficient. And we have solved a question regarding the absence of foam. And the answer was still what? Catalase, because catalase is not there, foam cannot be produced. So here, your answer is what? Is C. All right. We have a 62-year-old woman complaining of frequent pains in the area of her chest and the backbone and then the rib fractures. A doctor assumed myelomatosis. Guys, do you remember when I mentioned myeloma? When I mentioned plasmacytoma? Yes, we are talking about increase in what? In proteins. Increase in what? In proteins. Increase in proteins. And then another name is what? It's paraproteinemia. Paraproteinemia or paraprotein. You saw the similar question in the other ones, but they use what? Paraprotein. But this one, our answer is what? Paraproteinemia. So it's the same thing. So here, your likely answer is what? Paraproteinemia. All right. So we are having a newborn child with convulsion. That means the person is seizuring in a way, and has been observed after prescription of vitamin B6. So when the patient was convulsing, we give the person what? Vitamin B6. Now, the most probable cause of this effect is that vitamin B6 is a component of which of the following enzyme? It is a component of which of the following enzyme? So first of all, you must know what vitamin B6 is all about. Now, vitamin B6 belongs to a group of what? Essential nutrients. And its active form is called what? Paradoxical 5-phosphate. Paradoxical 5-phosphate. So P5P. And this is what? A coenzyme for many what? Amino acid. It's a coenzyme for a lot of what? Amino acid. And to be specific, it's a coenzyme for 5 important neurotransmitters. 5 important neurotransmitters. neurotransmitter. Don't forget, conversion has to do with what? With gamma. With gamma. With gamma. GABA. Gamma. Or gamma aminobutyric what? Acid. That's the full name. So when these gamma are released, it then causes what? The brain to function that way, to be seizuring and to be going through those what? Spasms. Okay, so now back to the PLP, or the paradoxical 5-phosphate. We are saying that it's a coenzyme for 5 important what? Neurotransmitters. And these are serotonin, these are dopamine, epinephrine, norepinephrine, and then the gamma. And then the gamma. And then the gamma. But how do they function? They function through a process called what? Decarboxylation, or glutamate decarboxylation. Glutamate decarboxylation. So this is actually an enzyme that catalyzes the decarbonylation of what? Glutamate to the gamma. It catabolizes the decarboxylation of what? Glutamate, or it catalyzes the decarboxylation of what? Glutamate to the gamma. To the gamma. So when you actually give the vitamin B6, it goes on to what? To inhibit those gamma cells, or those gamma neurotransmitters, and hence reduces what? The conversion present in this patient. So here we're definitely going for what? Glutamate decarboxylase. Glutamate decarboxylase. So here your answer is A. A. All right. So we have what? Nappies of a newborn. And we're having what? Dark spots. That witness of the formation of, so this is your guy, homogentic acid. Homogentic acid. The question now is metabolic imbalance of which substance is connected here. So before you can answer this one, you need to know what this homogentic acid is all about. You need to know what it's all about. So first of all, it is an aromatic what? Compound. When we say aromatic compound, something that's what? Has that sweet smelling fragrance. And it involves in the breakdown of amino acid. And these amino acids are tyrosine and phenylalanine. Tyrosine and phenylalanine. So when they say there's a problem with this homogentic acid, what it means is that there is a metabolic imbalance of what? Tyrosine and phenylalanine. Now, when you look at our option, our right answer would what? Would be tyrosine. 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 So quickly, we'll go in for what? For B. We'll go in for what? For B. Now, look at this question here. We've done this one already, but it has been formulated in a different way. That tells you again that Krok will always repeat their question. They have no new set of questions present. Now, look at this question again. There's what? Copper concentration. And it was decreased, but in the blood, in the urine, it was high. Wilson disease was diagnosed. Again, what do you use? Of course, you use what? Your ceruloplasmin. Ceruloplasmin. So your answer is what? Is A. As simple as that. Again, what is the use of the xanthine oxidase? It has to do with what? Uric acid. We've spoken about this severally today. Severally today. So please don't get confused with Wilson disease under no circumstance. All right. What do we have? We're having a 50-year-old patient complaining of general weakness, loss of appetite, and cardiac arrhythmia. The patient presents with hypotonia. That means the muscle is quite what? Weak. And there's what? Flaccid paralysis. That we can't even lift it up. There's weakened peristaltic activity of the bowel. Which such condition might have been caused by what? By what? By what? by what? So usually, so basically we are thinking about what? Potassium. We are thinking of what? A potassium. Because potassium is needed for repolarization of cell membranes. It is needed for what? Repolarization. That is why when people are having this imbalance of, how do you call it? Imbalance of erythrocytes. Sorry, imbalance of, how am I even forgetting this thing? Electrolyte, sorry. Imbalance of electrolyte. Imbalance of electrolyte. One important thing that comes to mind is what? Is the potassium. One important thing that comes to mind is the what? The potassium level. The potassium level. And when potassium levels are decreased, cell membranes will not be able to what? To undergo repolarization. So here we are thinking of what? Hypokalemia. 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 All right. We are having an 18-year-old patient has an enlarged inguinal lymph nodes. They are painless. Guys, this is your clue. They are painless. Thickened on palpation. The area of the genital mucous membranes, there is small size ulcer with thickened edges and lacquer bottom of grayish color. What are you thinking about? Definitely you are thinking of what? Syphilis. Syphilis. Ladies and gentlemen, you are thinking of what? Syphilis. Or sexually transmitted what? Infection. This is what? Syphilis. And why is it so? Because in syphilis, we're having what? A lot of sore around the genitals. But these sores are painless. These nodes are painless. They are painless, but they are there. They don't cause scratches or itchiness. They don't cause itching. But these are there plenty, and they are painless. 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 So, and of course, it can even occur in the mouth and all these places. So here you are thinking of what? Syphilis. 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 All right. I love this question because Dr. Yara asked this question. Now look at it again. They said concentration of pyruvate is increased. Increase. What comes to mind? Of course, vitamin B1. Vitamin B1. So that means that there's deficiency of vitamin what? B1. I've told you guys. In vitamin B3, we are thinking of what? Pellagra or niacin or nicotinamide or the 3Ds. Okay. I love biochemistry. Guys, do you remember this guy? Carnitine? Carnitine? Yes. What's the mechanism of action? It transports fatty acid from the cytosol to the mitochondria for it to be oxidized or what? Or burned. So here you are going for what? For D. We've done this already. So transport of fatty acid from the cell or the cytosol to the mitochondria. All right. We're having a patient with suspected diphtheria. Suspected diphtheria. Went through bacterioscopic examination. Now, examination of a throat swab revealed rod-shaped bacteria with volatile granules. What ethiotropic preparation should be chosen in this case? What should be chosen in this case? So definitely, this is what? A diphtheria. It is what? A diphtheria. So how are you going to manage this person, or what preparation should you do for this what? Etiology. So definitely you do what? Definitely there's a presence of what? Of diphtheria. there is the presence of what? Of diphtheria. So what do you give? You give anti-diphtheric what? Antitoxic serum. Anti-diphtheric antitoxic serum. That is what you give. You give what? Anti-diphtheric antitoxic serum. That is the choice that we give over here. Now, diphtheria antitoxin. Diphtheria antitoxin is more or less made up of what? Antibodies. It is made of what? Antibodies. It is made of what? Antibodies. But in anti-diphtheric antitoxin serum, it is used as both curative and prophylaxis. So you can use it for both what? Curative and what? And prophylaxis. But with the diphtheria antitoxin, it is only used for what? For the treatment, because it contains what? Antibodies. So it is used for just what? The treatment. But we are looking for something that can protect and can also cure. That's why we are going for what? Anti-diphtheric antitoxic serum. Antitoxic serum. If the question had been what will be the method of treatment, then perhaps we could have gone for what? Diphtheria antitoxin. Diphtheria antitoxin. But over here, we are looking at what? The etiologic preparation. So we want to cure and we want to what? We want to prevent it from happening. So here we'll go in for what? For E. For E. A patient with diabetes experiences loss of consciousness. Now, diabetes means what? Too much of what? Sugar. Now, there's loss of consciousness and convulsion. And this occurred after giving insulin. And we know that insulin will do what? Will decrease what? The glucose in the blood. Insulin decreases glucose in the blood. So perhaps this person has gone through what? Hypoglycemic coma. Hypoglycemic coma. Hypoglycemic coma. And at what point do we say this person is not in hypo? Of course, sugar level, that is what? Less than 1.5. Less than 1.5. Less than 1.5 millimole per liters. Less than 1.5. All right. We have a woman who has been keeping to a clean rice diet for a long time, was diagnosed with polyneuritis. That's beriberi. What vitamin causes beriberi? What vitamin causes beriberi? Of course, vitamin what? B1. Vitamin B1. So apart from pyruvate increasing, it also causes what? Beriberi. So take note, apart from pyruvate deficiency of vitamin B1 causing increase in pyruvate, it also causes what? Beriberi or polyneuritis. Beriberi. So you are thinking of what? Thymine. Vitamin B1 is the same as what? Thymine. So here your answer is what? Is B. All right. We are having the removal of the gallbladder of a patient has disturbed processes of calcium absorption through the intestinal wall. What vitamin will stimulate this process? Guys, we want to absorb what? Calcium. So what has to do with calcium? Of course, vitamin D3. Vitamin D3. So another name for vitamin D3 is what? Cholecalciferol. And it helps in the absorption of what? Of calcium. It helps in the absorption of what? Of calcium. And sometimes when you go, sometimes in the morning, they'll ask you to go and stand in front of under the sun. So when you stand under the sun, you are actually getting what? Vitamin D3. So, and it prevents what? Rickets. It prevents rickets. So over here, there is a disturbed process of what? Calcium absorption. So you want to increase the absorption. And what do you give? Vitamin D3 or cholecalciferol. So your answer is A. Good. Now we have a 63-year-old woman developed signs of rheumatoid arthritis. There's an increase in which indicated blood value levels could be helpful in providing what? Like, I remember we did something about rheumatoid arthritis, and we said the high amount of the connective tissue, it is in high abundance of what? Of collagen. They are in high abundance of what? Of collagen. Now the next one is what? Glycoaminoglycans. So sometimes if you don't see collagen, which over here we didn't see collagen, if collagen was present, we would have easily going for what? Collagen fibers. And that means you will see what? Proline, the lysine, the glycines, like we rightly what? Discuss. Am I right? But in the absence of these things, the next tool for diagnosis of or confirmation of rheumatoid arthritis is the presence of what? Glycoaminoglycans. So here you are thinking of what? Of A. You are thinking of A. All right. Good. We are having a 1.5-year-old child presenting with both mental and physical lack. When we say mental and physical lack, that means there's a retardation. The person is not growing well. There is decoloring of the skin and then the hair, decrease in catecholamine concentration. Catecholamine concentration is decreased. And when few drops of 5% solution of trichloroacetic ion had been added, the child's urine turned olive green. Such alterations are typical for the following pathology of amino acid metabolism. So actually, this is actually talking about what? A problem with what? With phenylalanine. And I said when there's an increased level of these in the urine, we call it what? Phenylketonuria. So over here, that is what we are thinking about. And of course, these are also involved in the metabolism of what? Catecholamines. They help in the production of what? Catecholamines. But here's the case, they are being decreased in the blood because they are being excreted. So if they are being excreted, what it means is that they what? Decreased concentration of what? Catecholamines. Decreased concentration of what? Catecholamines. So here, we would definitely go in for what? Phenylketonuria. But it has to do with a problem with what? It has to do with the problem with what? Phenylalanine. So here, we simply go in for that. And everything other thing here points towards it. So here, your answer is what? Is B. Good. I love this. A patient complains of frequent diarrhea, especially after consumption of fattening food and of body weight loss. Guys, look at this. There is what? Steatorrhea. Steatorrhea means what? Increase of fat in feces. I think we did this one the last time, and we said when there's increase of fat in feces, it means what? There is inadequate what? A bowel for emulsification of what? Of fat. But look at this. They say there's what? There's hypocolic feces. When we say hypocolic feces, it means feces is what? Is colorless. Feces is what? Is colorless. Feces is colorless. So what happens? You remember, it means there's too much of what? Conjugated bilirubin. You remember, conjugated leads to what? Colorless. However, that is not the main focus. The main focus is what is the cause of this what? Steatorrhea and this what? Colorless feces. It could be because there is a blockage of the release of the bowel. There's a blockage of the release of the bowel. And we know that the bowel moves in what? In the biliary what? Tract, or in the bowel duct. In the bowel duct. So when there is an obstruction or when there is a blockage in that place, what happens? It means bowel will not be released, or bowel will not be allowed to go and digest the fat foods or the fried rice. Do you get me? So here we are thinking of what? Obturation of the biliary tract, meaning that there is a blockage of the bowel duct. Hence, bowel are not able to reach the food that you ingest in, and hence they are not able to emulsify or digest the fat. They're not able to emulsify or digest the fat. Okay. We have on an empty stomach, the patient glucose level is 5.6. Then in an hour later, after usage of the sugar, it was 8.55. 2 hours later, it became 4.9. This is actually what? Normal. Normal. It is normal. Don't forget the normal range is from what? 3.5 to what? To 5.5. 3.5 to 5.5. Now, after eating, of course, if you take too much sugar, at that time, the sugar level will go high. But after 2 hours, when the sugar has now been digested and be absorbed, it now gets what? Within normal, 4.9, almost 5. And we said the normal range is from what? 3.5 to 5.5. So this means that this person, or the indicator here, is typical for what? For a healthy person. For a healthy person. And assuming after 2 hours, the sugar level was maybe 8 or 9, we could say that this person is what? Is diabetic. This person is diabetic. So here we are talking of what? A healthy individual. A healthy individual. Okay. A child is languid, apathetic, liver is enlarged, and the liver biopsy revealed a lot of what? Glycogen. Guys, do you remember glycogen? Glycogen is the storage form of what? Glucose in the liver. The storage form of glucose in the liver. I think we solved this at the beginning of the biochemistry, where we talk about glycogen storage diseases. Glycogen storage diseases. Now, they are saying that the glucose concentration in the bloodstream is below normal. What is the cause of this low glucose concentration? What is the reason? What is the reason? So normally, what helps us to release sugar from a stored glycogen, because sugar is stored in the form of what? Glycogen. So to release the sugar out, or to release the glucose out, it has to use an enzyme called what? Glycogen phosphorylase. It uses an enzyme called glycogen phosphorylase. So in the case whereby there is a deficiency of this glycogen phosphorylase, what it means is that the glucose cannot come out, even though the body needs it. But there's no enzyme to stimulate the release of the glucose, or there's no enzyme to signal the liver that glucose need to be released. There's nothing to show. So over here, we are thinking of what? A low or absent activity of glycogen phosphorylase in the liver. In the liver. So here, your answer is what? Is D. Is D. All right. Now we have a 65-year-old man. Guys, look at it. Suffering from gout. We've spoken about this like 100 times. So gout means what? Uric acid is what? Present. Uric acid is what? Present. And again, we spoke about what? About purine. That it is gotten from what? Purine. And to specific, we are talking about what? The adenyl what? Monophosphate, right? Adenyl monophosphate. Adenyl monophosphate. And then we are saying that the enzyme that is involved in the final release of the uric acid is called what? Xanthine oxidase. Xanthine oxidase. Xanthine oxidase. But this is not a question about xanthine oxidase. The question now is that the most probable cause of this calculate formation is the concentration of what? Of course, uric acid. Uric acid. So here, your answer is what? Uric acid. So A is your answer. You see, medicine is good